So 34% of you have put less than 4. And that, of course, is right in the context of a patient with type 1 diabetes who's on insulin. I think they say 4 is the floor. And of course, the context there is that when they have had their insulin, if it's 4, it's going to be falling and it might fall. But if you have not got diabetes and check your blood glucose, quite often it's below 4, 3.8, 3.9. It's a perfectly normal number. And then there's less than 3, less than 2.5, and then a number of endocrinologists, I think, who put less than 2.2, which is the context of an insulinoma. And then 2 people have put ENF, and they're not options. Okay. So let me just tell you a bit about, defining hypoglycemia and why it's important and what the context is in each case. So yes, here we go. We say to people with diabetes, 5 don't drive as it falls, because if you get to 4, it might fall. And the problem is, as your blood glucose falls, first you get sympathetic activation, which patients call a warning, between about 2.5 and 3.5. And that number moves down in people with very tight control. If they're on low a lot, then your sympathetic activation falls to a lower level, which means that they lose awareness. That's how they call it, because the warning happens at a number that they're still alert. And the problem is, as the glucose continues to fall, as you know, you become confused when you go below about 2. But you're right, we tell patients that less than 4 is a hypo. And the problem with saying that to ambulance staff is that that does not apply to normal people. And the problem is, when you have somebody who has not got diabetes, who's got, say, a family history, and they check their blood sugar for no particularly good reason, except they've got a Freestyle Libre from their friend, or they just think they'll do it, they go, oh, it's 3.9. That's the time when we tell my type 1 diabetes friend to quickly eat something, and therefore I must be ill. So that's a problem, because ambulance staff bring patients into casualty with blood sugars of 3.8 because it's a hypo sometimes. Now, this graph is to demonstrate what happens to blood glucose and insulin levels with breakfast, lunch, and dinner, okay, in a normal, healthy person. And you'll notice the axes are very different. So the left-hand axis is the glucose in millimoles per liter in brown, okay? And notice it does not start at 0, it starts at 4. So it only goes from 4 to 6 normally after a meal, okay? It barely moves. Whereas the insulin is on the right-hand axis and goes from 0 to 300. And you'll notice with breakfast that insulin goes from less than 50 to 250. So a 5-fold increase in insulin for a glucose that goes up less than 50%, yeah, from 4.2 to 6.2. So what basically the endocrine system is involved with having a hormone that controls the substrate. And the hormone changes a lot with the aim of fixing the substrate. That applies to everything. So if you look at calcium, calcium barely moves, PTH shoots up and down depending on what you've eaten. Okay, this applies to everything, but it's particularly pertinent in glucose and insulin here, as you can see. And then it depends on how big and how glucose rich and the glycemic index of the food. So look at lunch, there's several options there. So if you have a sort of standard lunch starch, then the glucose goes up to 6 with an insulin that goes up to 200. But if you have a very sucrose-rich meal, then you have a much higher excursion in the glucose. Not much higher, because it only goes to 6.5, but the insulin vastly increases, okay? So the insulin changes a lot, and then after you have that huge meal, the insulin falls as the glucose to lower than normal, well, lower than the other people. It's still normal, okay? There's no hypo here. This is just a normal curve with different meals, okay? But 2 points, the glucose doesn't change much, the insulin changes a lot. So then if you look at people who are fasting, and we are now going to think really about moving from diabetes to patients who have not got diabetes but might have an insulinoma and might be hypoglycemic, you need to forget all the things we teach in diabetes about the dangers of hypoglycemia, because the targets are going to be much lower, okay? And if you look at these levels of insulin, you can see absolutely rocket after you have any glucose, okay, and fall to low levels of less than 25, okay, and that's our detection limit is not good enough. So normal fasting insulin in picomoles per liter is 18 to 100. That's a big range, but if you're fasting, it's lower, and if you have a meal, it goes up, okay? As you know, insulin is a message you've had a meal. So what happens if you really fast for 3 days? Okay, this is a 72-hour fast in a healthy volunteer. The blood glucose starts at 4.8, okay, and this is several people, okay, physically fit men from quite a while ago, actually, 2002. The green line is at 3.4, okay, and the blood glucose falls and falls and falls a bit between 24 and 48 hours, and then it doesn't go much below that because everything else brings it up, and insulin levels will obviously drop. I'll show that in a minute. And then if you go past 72, which you don't normally do, it's going to 80 hours. If you keep going, then the glucose doesn't fall, but it starts to rise, okay? So when people say, I'm having a hypo because I had any lunch, they're not having a hypo, they're just feeling hungry, okay? And that's a very common misconception among patients. They say, I'm having a hypo, but really they're just hungry, okay? And if the blood sugar is 3.2, that is absolutely normal. So for insulinomas, we need a really low glucose. Here's the insulin at the same time, okay? The insulin goes from 32 right down to just over 10. So because there's no carbohydrate in this patient's diet, because they're not eating, they're starving, okay? The glucose goes down, from 4.8 to 3.4, and the insulin goes down from 32 to 10, okay? And then it rises at the end, like the glucose. So clearly that is not due to a fall in insulin at the end, it's due to adrenaline, cortisol, all these stress hormones pushing the glucose back up again. So you have good counter-regulation, okay? So here is a poll question, okay? And I'll just tell you the story before Kavita puts the poll up. Young person comes to A&E with an inverted commas collapse, not known to be diabetic. The ambulance pick a finger and it's 2.8, and they take a deep breath and go, oh my gosh, it's a hypo. And they give some hypostop and some glucose, and she wakes up and she arrives in casualty. And I want you now to poll. Can you put the poll on? The blood glucose when she arrives in casualty, where you are, is 3.9, okay? Great, okay, so you can just A or B. I want you to tell me if the glucose is 3.9, whether you will also send a sample for insulin at the same time. So A is yes, I will send a sample for insulin, and B is no. And the story is on the page there, right? You can move the poll thing around if you want to read the text underneath, but the key points are the ambulance glucose was 2.8, the glucose now is 3.9, and she's looking okay, and you have the chance of sending a sample of glucose and insulin. A, yes, B, no. Now let me ask, Kavita, how many people have answered? Is it a good time to reveal?
47, 48 of 70. So we'll wait a bit.
Okay, wait another 10 seconds. Come on, everyone. Just choose A or B, okay? It's not that difficult. Okay, should we reveal?
Yeah.
Mm-hmm. Okay, so helpfully, most people have correctly said, no, don't send an insulin. And the reason you must not send an insulin is that they've given the patient some hypostop. And I showed you earlier that the minute you have any glucose, the insulin absolutely shoots up, it rockets, okay? And so you don't want to measure an insulin because it will be high, and then everyone will think, oh, she's got an insulinoma because the insulin is high, okay? So we definitely don't want that. So the answer was no. So if they had sent it, this is what happens, okay? So she now comes to main outpatients where you happen to be the registrar in the endocrine clinic, and here are some options. Do you want to poll again? Okay, so the blood glucose was in A&E 3.9. The insulin was 540 with a reference range there, and the C-peptide was 1,500. And I want you to choose A, B, or C. You've got 3 choices. You heard the story, yeah? Glucose was 2.8 in the ambulance. Do you want to say, there's nothing wrong with you, I'm going to discharge you, congratulations? Do you want to go for B, a 3-day fast, or do you want to go for C, some imaging? Okay, do you want to reveal? I don't know how many have done it, but I think that might be enough.
Yeah, I will just end the poll now and share the results.
Okay, so a bit of a spread. So a third of you want to discharge her because she's almost certainly normal. Some of you want to prove that by going for B, that's 62%. That's not unreasonable. And the 6% imaging is not a good idea. You don't want to image someone until you know what you're looking for. Okay, so I will say that A and B are both correct. But C, it's very important not to image people because otherwise you find adrenal incidentalomas and this and that and the other. Okay, so in someone like this, okay, who's got a past history of similar collapses, I'll tell you now, but never had a glucose check previously and no other relevant history and a stable weight, any thoughts as to the likeliest diagnosis? Maybe I'll...
People can put in the chat and then I can read the result.
Right. Yeah, that would be good. Mm-hmm. Okay, you've all got it. Yeah, she's got it.
Bagel.
Mm-hmm. That's really common. Now, sorry, I'm eating too. When you eat, if you feel hungry, you eat. And if you eat, you feel better. And one of the problems with feeding people when they're hungry, if they think they've got a glucose problem, is they think the glucose is the problem. So there's a question there. Do you want to just tell me what you mean? That was Amna. Oh, or okay.
I think when you said with the ambulance, it's likely a capillary glucose.
Indeed. Yeah. That's also true. So it's less accurate, okay? But the other thing is that patients think that their blood glucose drives their symptoms, but that's not true. Hunger happens all the time. And if you check a blood sugar and it's a bit low, you put them together erroneously. So that's the danger. So here is golden rule number 1 for the 6% of you who put imaging. You must not image a patient unless you have proven they have a hormone problem, if you're an endocrinologist, that is, okay? Because if you image without that, you're going to find things that are of no consequence, okay? It's got to come from the history. So if you do an MRI abdomen, you're going to find all kinds of lumps and bumps and then cause a lot of anxiety. So you really need to verify there is a tumor there. The purpose of imaging is to find it and remove it. And then, if you find a lump, you need to be sure that that is the source of the problem before you operate. So I'm going to spend a minute talking about insulinomas. Okay, sneak an iron portal in. Well, that could be dangerous because it might be a bit low because the patient had 2 cups of Beckley Forte just before they came in, for example, okay? And so there is a risk. I mean, what I'm trying to re-emphasize in all of endocrinology is the risk of a false positive. But you're right. And if this, you see, I'd like some other clues for cortisol, like a high potassium and low sodium or other things. It's very easy to get misled. I see a lot of patients who turn out to be normal, who've been labeled with some disease or other. So, of course, an insulinoma, you know, is a benign tumor that makes unchecked insulin, okay? And if you have an insulinoma, then, of course, you will become hypoglycemic when you don't eat. So, like first thing in the morning before you've had breakfast, you might be more likely to be hypoglycemic. But the patients think they're just having dizzy spells or finding turns and give it various odd names, but they are made better by eating. But the problem is all of us feel better when we eat, okay? And the problem is that mostly people don't have insulinomas, and therefore I really want some good biochemical evidence, okay? And the problem is, as I showed you, there's big shifts in insulin with a small shift in glucose. And so a lot of people have, if you fast, an insulin of about 50, which is normal, okay? And that's the problem of just fasting overnight. So the second rule is you can't interpret an insulin level to say it's it's abnormal unless the glucose is less than 2.2, okay? And that's because you saw the exponential fall in insulin levels as the glucose falls. And when the glucose in that in the normal person went no lower than 3.4 in the group of normal people. So if it does fall further, but doesn't quite make it to 2.2, then it's probably normal, okay? And that's because the insulin should fall with it. And I'll show you some numbers to explain it, right? So as I've said twice now, the most important thing you do is maintain a fixed concentration of something like glucose or calcium or thyroxine with big shifts in the other thing like insulin or PTH or TSH. That changes a lot, okay? And of course, the other thing that you want to do in someone who you think might have a tumor that makes insulin is also measure C-peptide, okay? And people say, why do you need to measure C-peptide? And of course, all of you know that you need to make sure the patient is not self-injecting insulin, which seems amazingly unlikely, except that madness is a very common problem, okay? So this, to remind us all, is the insulin molecule. The top half is pre-proinsulin with the A and the C peptide in the middle and the B chain, and there's a disulfide bridge there, and you basically chop off C-peptide, which is then okay, which is then cleaved off and you can measure it. Now, in one lecture you heard you want to measure the insulin if it's less than 3. So the problem with less than 3 is it'll be a lot higher than less than 2.2. Okay, and the problem therefore is you are likely to have a false positive. You need to keep going. Now, supposing you say, listen, I'm gonna be efficient. I'm going to only do a 24-hour fast. That's not wrong. That's not unreasonable. But we haven't got valid cutoffs. Okay, so if you then say I'll do a 1-day fast and I'll measure the glucose and it's 3, and the insulin is, it'll be a bit higher than 10. We haven't got a good reference for insulinomas, and because they are so rare, it's definitely worth doing the whole thing when you really want to prove it, okay? And that's why you want to take it to below 2.2, because if it's less than 3, they're not an insulinoma. And if you do the insulin, it'll be more than 10. I think I've got a slide come up which shows that actually. So just remember that when you buy insulin in a bottle or in a needle, it does not have C-peptide, and therefore if you self-inject insulin, you'll have a low glucose, a very high insulin, and no C-peptide, okay? And that will give it away, sky-high insulin without C-peptide. Now, we have a problem because patients are patients, and the Munchausen group, who would like to have surgery for some odd reason, take insulin with gliclazide, which pushes up the C-peptide. So you therefore need to be really careful about those people, okay? And the problem really is that for every patient we actually do find an insulinoma, we've got 2 people who either fake it or haven't got one but think they have, okay? And that's why we measure urine or plasma now for sulfonylureas. You want to prove they're not also having gliclazide. So to prove you have an insulinoma, and before you start imaging, you want a properly low glucose with an inappropriate insulin and a high C-peptide, and also prove they're not taking gliclazide. In that situation, we should start imaging. Are there any questions about that? I mean, whatever test you do will have a false positive and a false negative rate. So the more stringent you are, the better your predictive value of the test. But I know we're living in a real world, and maybe that's not always possible. And so you want to keep clues on the way. Now, the next thing is, once you've proven it, once you think this is definitely one, you want to image. And there's a number of different imaging modalities, like all the old ones which are on this page, okay, like CT and ultrasound are not very sensitive. Oxy scanning wasn't great, but we've now got gallium, which is a lot better, okay? Gamma is a very good pickup rate for insulin. I'll show you a picture later. And then once you've done that, you want an EUS, you want an endoscopy, an ultrasound on the inside to see the head of the pancreas, to see if you can see it. And that's really that combination gives you a very high chance of finding a real insulinoma. But if you're in any doubt, then you can do this and some angiograms. Okay, one of the problems with just imaging without functional is that you're not certain that the source of the tumor in ultrasound or CT is the cause of the insulin, whereas you are sure with a gallium scan, for example, because you can see uptake. Has anyone got any questions? Okay, so let me show you another case, okay, to explain what I'll be trying to say. So this patient was referred from another center saying, we're sure they've got an insulinoma. Can you localize it for us? So they'd done a fast, much better, yeah? Within 3 hours, 1.8. That's much more suspicious. And they had also done it properly. Insulin was 34, C-peptide 700, and they looked at glycoside and it was negative. So they were pretty competent. So this is the glucose. I'm putting where this patient glucose, so 3 hours into the fast, the glucose is down to 1.8, whereas in a healthy volunteer, it takes 3 days to get there. So this is a very aggressive insulin, a lot of insulin, and it's pushing the glucose down very, very fast. And the insulin was normal, 34, but not appropriate for this glucose, okay? So you'll see that what should happen is the insulin, when the glucose gets down to 2.2, and this one 1.8, should be less than 10, but it was 34. Now you might say, well, that's normal, but it's not. It's highly inappropriate, and therefore, this patient looks like they've got an insulinoma.
There's a question, Prof, in the chat about, do you think capillary glucose is as reliable to decide compared to plasma glucose?
No. So in the fast, right, what you should do, because it's quite difficult to do blood samples every few hours like this, okay, obviously this is a study, we do capillary blood sugars like this, okay, and if they have an insulin and it starts to fall and the capillary glucose goes to less than about 3, we would then do a blood glucose and a blood insulin. Don't terminate the fast, okay? Wait for the lab to ring you up and say the plasma glucose in the lab is 2.1 or 1. If they do that, you sent the insulin, you can then say, right, we've got a definite hypoglycemia. We just need to wait for the insulin to come back. The other test you do at the same time is you measure plasma ketones, like we do with patient diabetes, because if you have insulin, you will suppress ketones, okay? So normal people don't make ketones initially, and then as the insulin falls when they fast, they make more and more ketones. Whereas if an insulinoma, you don't make ketones. Okay, so there's an added piece of information there. Can you please repeat what you said about less than 10? Oh, the insulin. Yes. Okay, so let's do this again, right? So the plasma glucose in a normal person goes down to 3.4. My patient's got a glucose of 1.8. Okay, what's the insulin? I move to here. In a healthy person, the insulin starts at about 34. Her insulin was 34, exactly. But that is inappropriate because you see what should happen, the insulin should fall to 10, that's where it's 10, right? But only when the glucose is very low. So this insulin, while it's normal for 3 hours, it's not normal for a blood glucose of 1.8. It's way below this, and therefore the insulin should be way below 10. So that is the way to be sure. And when you've got these kind of things, you then want to proceed with imaging. This data that I've got on this page is really convincing, and you can talk to the center that did it and check that nothing went wrong. But if they've done it properly, you don't need to do all again, okay? It should be. I'm just going to move on, Kavita, okay? So you can end that poll. Okay, and someone put proceed with imaging. Quite right, okay? Right, let's keep going. So they've done it. So what had happened, right? They sent the patient for us to look at because they said, we have done all the tests, the definite insulinoma there, but we can't see it. And they've done a whole CT with and without contrast and an MRI, and nothing showed up. So they don't know where the insulinoma was, but they were pretty sure it was there, okay? Here is the scan. So there's the liver, there's the stomach, and I'm going to scroll, okay, through it, because I've made lots of pictures of this patient's abdomen. Nice, normal abdomen. There's contrast in the stomach, okay? You can see the spleen at the back here. And there's the pancreas. There's a pancreas there, okay? And there's the spleen, and there's the liver, okay? And no sign of anything really that they could see. They looked at it very carefully, as did we. Okay, so the other thing you could do is venous sampling of the pancreas to see if the pancreas is got any source. Okay, but the problem is that the venous drain of the pancreas goes to the liver through the portal vein, so you can't cannulate it easily. Okay, you can't go into the IVs, you can't go to the groin and go up into this because this is a different venous system, the portal system, it goes into the liver. So taking blood from different parts of the pancreas is not possible. Okay, and so what we do is inject calcium into the arterial supply. So here's my little diagram to explain that. So you put a line into the aorta, okay, through the groin, femoral artery, push it up here, you thread it into the SMA, and you inject calcium. And if the insulinoma is here, then it will degranulate and release a load of insulin. And then you come out and you go into here and do the same thing, calcium, okay, 1 ml calcium gluconate. And then you do it into the splenic. And then you can see whereabouts the tumor is. It'll give you a clue. And you also get a tumor blush. Okay, so use 1 ml of 10% calcium gluconate. This is done by radiology. And this is them showing me a picture of where they thought, there it is. Okay, so they gave contrast. And then there's a delayed, okay? So they inject it first, you can see all the vessels showing out. This is a digital subtraction angiogram. So they take an X-ray, they inject contrast, take a second X-ray and subtract the two, and you're left with the blood flow. And then you wait for a few more seconds, and the blood goes from the artery into the spleen, okay? And the tumor hangs on to the contrast a bit longer, and therefore it becomes more avid. That's called a tumor blush. You hear that term, okay? So that sounds like there's the source. But what you then do is you inject calcium into each of the arteries supplying this, and you look to see which one causes this thing to release a lot of insulin. Okay. And you take basically blood every 30 seconds. Your radiologist puts cannulates each thing, and then you take and you measure the insulin. So here's the results. So what you do is you inject first calcium into the hepatic artery, and you'll see 2 baseline samples, and then no rise. Same splenic, completely flat. When the GDA, big rise in insulin when you inject calcium into the GDA. So you know the GDA is the blood supply of the insulinoma.
Prof, there's some questions on the chats. I think there was one from Sophie and one from Rana.
Okay.
Is there any mathematical calculation for determining abnormal insulin-glucose relationship?
No, there isn't. That's why you've got to get to below 2.2, okay? Because we've always looked for a relationship saying, well, what if it's 3? Is there a different? There is no correction. It's a very important point that you've made there, right? There isn't to say, if the glucose is 3, then it needs to be this. Because, as you know, there's a huge variance in insulin resistance in our population. So that makes that important. You've got to get to below 2.2, and then we have reference range for insulin, okay?
And I think the next question is about I think the slide of your drawing.
Okay.
So go back to.
I'll just explain. Yeah. So you put a cannula into the groin, you go up femoral artery into the aorta, you cannulate here, and then you inject calcium. And if the tumor's there, it will release insulin. You then come out, you go back in here, and you inject calcium there. And you come out and you do the same into the splenic, and you therefore have 3 sets. And when you inject calcium, you take blood peripherally, okay, take blood from a peripheral vein every 30 seconds. And this is what you see. So there's a registrar taking blood from the left arm every 30 seconds, and there's a radiologist who's very clever and can cannulate any vessel around, and you're taking blood every 30 seconds here, blood, no rise in insulin for 3 minutes, then you stop. Then he moves the cannula into the splenic artery in this case, and then he injects calcium, and you measure the blood every 30 seconds, nothing happens, and then you do it the 3rd time, and this time there's a rise in insulin. Now he said it'll be here. We don't see the results, of course, we just got lots of tubes, but he saw that blush and said, I know it'll be the GDA. So that's also a helpful, because you've got an image, but the only image was the tumor blush. So remember, the CT didn't show it at all. Okay, and that's the same data on a normal graph.
Apologies, Prof. I think they wanted to see the slide before the drawing.
Oh, before the drawing. Oh, this one. Yes. This one?
Yes.
Okay. So there's a tumor blush. So we inject contrast into the celiac axis, basically, that goes down the splenic, and there's a liver. Okay, so this is at the same time as the calcium stimulation. And he said, oh, there's a GBA source. Okay, good anatomists, these radiologists. And then they do the same thing, but they inject calcium into each of those branches. Okay. Okay. And then you discuss an MDT, and you look at the angiogram very carefully, and you decide, where is it? Is it operable? Is it laparoscopic? Is it an endocrine surgeon? Is it a hepatobiliary surgeon? And you'll decide, and you, the endocrine registrar or consultant, is the patient's advocate. Find out what the patient wants. Will the patient accept surgery? Because you can say this patient's frail, is not going to survive an operation, for example. That needs to be said. Okay, now more recently, we have got better imaging in the form of gallium PET. Okay, and remember, a PET scan is any scan where you give a radioactive substance or a tracer, and then you, and there can be different tracers, and then you compare with a CT. Okay, so gallium dotatate is the dotatate. Gallium is just the radiation. Dotatate is the peptide that binds to SSTR receptors. That's those that are somatostatin receptors, and they are present on any endocrine cell. Okay, there's none in the brain. You'll see some in the pituitary. There's lots in the spleen. I don't know why. The spleen is very full of SST receptors. Okay, so that's a gallium PET. You'll also have heard of FDG PET. So in your hospital, oncology have been using FDG PET for years. Okay, that's not new at all. FDG is fluorodeoxyglucose, and that means any cancer cell that's very glycolytic will show up. Okay, so that's just for normal cancers, but we don't want to do that. We use the same CT scanner with a PET scanner, but we give gallium-68 instead, and then you see a different picture. Okay, so here is a gallium scan on top of a CT. The CT is in black and white, the gallium's in color, and we're going to the head, and you can see the pituitary shows up. Okay, so the pituitary is pink. It's not off center really, it's because they do the CT first, and then they do the color on a separate scanner, and they merge the images. So it's slightly off center because they haven't done perfect merging, but it's pretty close. Okay, then you keep going down, there's nothing in the rest of the head. Okay, and then you get to the abdomen. I've missed out the thorax. The thorax is blank. There's no, unless there's a carcinoma tumor or something. So here is the liver and the spleen. I said the spleen is always hot. Okay, liver's warmish. Spleen is really very avid. And you keep going. There's the stomach. There's the same patient, and there is the pancreas. But look at that. There is the pancreas we saw earlier, and in it there's a really hot gallium avid. Dotatate avid, I should say, insulinoma. Biochemically, it was okay. Was there a question? Oh, okay, we'll keep going. Okay, there's the insulinoma, and there you go. So you can say to your patient, we found it. Okay, that was the patient with the CT didn't show anything at all. Two things important to remember. This is a gallium scan. Okay, so it's a PET, but it's not the same as FDG. FDG is looking for any cancer metastasis. And then the patient ended up with ultrasound, and cut a long story short, she had the tumor removed, and she is cured and in remission now. We're about 5 years later. Okay. Now, let me just move back to the patient who we mentioned at the start, who had that vasovagal, right? She discovered that we had gallium scans. Okay, this is the patient who, do you want to put the poll up here? So we're going back to my first patient who's really convinced that she has an insulinoma too, right? And I want you to tell me what you would do if she came to see you, okay? And the GP says that the patient's read all about this and has heard that there's a gallium scan available, and says, what harm is there in doing gallium scan? Because then you can prove to her that she is normal. Okay, and she says, no, I want a gallium scan because I'm sure I've got one. So A, refused gallium scan, and B, imaging with a gallium scan. Do you want to to reveal? Yeah, very good. Very tough people. Are we? Is that because we want to save money, or is there any other good reason to be so mean to this poor, anxious person? You want to put in the chat why you want to be so tough with the NHS funds, I suppose. Let me look in the chat and see if anyone's going to tell me. Yes, it's the false positive. I'm going to show you the false positive that she caused. Okay, so this is her. We didn't do this. She, there's a hospital not far from here. It's not a hospital. It's a clinic. You pay your money, you get your test. Okay. So they did this gallium scan on this patient. Two things to notice, right? The liver and the spleen are very white. Okay, and that is because in this private place, they have wound up the gain to try and see something. Okay, so you've made the radiation much. It's not hotter. It's just you change the windowing to make it easier to see things that are there. And the problem is it makes easy things that are not there. And this is my last patient, right? You see how the liver's pink, yeah, and the spleen is yellow. In this patient, the liver's bright white and the spleen is bright white, so it's really wound up. So anything that's a bit warm is going to show up, and that is a problem. So this, I'm just going through this, okay? And there's her point. Okay, do you want to put the poll up again? She says, I've got one. I knew it. Is it insulinoma? You've got three choices. Yes, no, and needs more tests. A, B, or C.
Prof, in the interim, do you want to answer some of the questions in the chat?
Yeah, go ahead.
There was, can we get away with convincing dotatate localization without calcium stimulation tests as it's more invasive?
Yes, we've stopped. We only do the calcium stimulation test when the dotatate doesn't show us, because 20% of them it doesn't show up. I don't know why. So they get the calcium stimulation test. But yes, you don't need to do both. Once your MDT are happy, you can go ahead.
Okay, I'll just give 10 more seconds before I stop the call. Yep, okay.
So no, one person's put yes, I think, or 2%. Most of you said no, but some say needs further tests. Okay, so I'll tell you, she doesn't need further tests. She needs to be told clearly this is not an insulinoma, because this is the answer. Basically, you get hot spots if you wind it up this much. And we need to reassure her that this is definitely normal. It's the background radiation that you get in the gut when you wind up the gain like this. And so I'll be keen to try and reassure her and stop doing more tests, because the more, every test has a false positive rate, and there's radiation hazard, yes. But my main problem is the false positive. Even imaging, you see, you think, oh, imaging can't have a false positive, and here you are. I've shown you a false positive. Okay. The other thing to say is the unset process of the pancreas also is warm. And when these first came out, a lot of people were saying, oh, there's a tumor there around the unset process, but now we know better. So more tests are the last thing she needs, because she's anxious, it will generate more anxiety. You've got to stop, okay? Because this is the previous nice insulinoma, okay? And this patient does not need more tests. So that is where we are now with imaging and getting tumors out, and angiography is becoming less and less needed. Endoscopic ultrasound is very sensitive, but not specific, because you can't tell what it is, and that's why the gallium scan is so good. Okay, I'm going to stop because I overrun a bit, and if there's any other questions, but I don't know if our next speaker would like to share her slides, Parry.
I think Parry's already in the meeting.
Yeah. I'm going to just look at
I
questions.
am. I'm just sharing the slides.
Thank you so much for doing the talk, Parry. So Parry is one of our diabetes endocrinology registrar, as well as an honorary lecturer at Imperial College, and she will be giving us a talk on inpatient use of CGM.
Kavita, I might just need to restart this. Bear with me 2 seconds.
No worries. Thank you very much, Prof, for the talk.
Here we are, there's some questions. Let me answer these questions. How does let me just put my camera on, sorry. It was on. So the question was, yeah, how does EUS help surgical plan? So I'll tell you, you've got to attend MDT. It is amazing, right? But when the surgeons are obviously correctly very concerned that they'll cause pancreatitis, and so if the tumor is right next to the pancreatic duct, they want to know. And an EUS is really helpful for that. So that's why they want to know. And so they will ask for that because it's like a map, it's like a road map. And the second question is glycoside and insulin. So if you are normal and you inject insulin and have a hypo, the patients know, those in the know that what you will do is you'll measure the insulin and C-peptide and you'll discover that it's low and therefore you know it's fake. So they take glycoside as well. And glycoside stimulates your pancreas to make your own insulin and C-peptide. Okay, but you won't make it hypo, then you have some insulin as well. But when you do the blood test, you find insulin is high and C-peptide is high and the glucose is low. And then the patient ends up having inappropriate surgery. Right, I can see that Parry's got her slides up. So I'm going to hand over to her and say thank you very much.
Thank you. Thank you, Prof.
Thanks. So hi, everyone. Thanks very much for joining on for the next session. And thank you for the introduction earlier, Kavita. So I'm going to be talking about continuous glucose monitoring in hospital, and that will be on behalf of the Joint British Diabetes Societies for Inpatient Care, for which the guidelines will be coming out later this year. So I'm going to give an overview in terms of CGM, but I think most of you on the call today are going to be quite familiar with that. And then I'm going to be talking a little bit about CGM on the wards and in the critical care setting, as well as in surgery and radiology settings and in cardiac arrest. And then we'll talk a little bit about glycemic targets in hospital, as well as alerts and alarms. And if there's a bit of time, we can talk also about hybrid closed loops. I'm very happy to take questions along the way, and Kavita, just in case I can't see them come up, just stop me as I'm going along. So continuous glucose monitoring. So most of you will be quite familiar in that these devices are subcutaneous devices that allow us to assess the direction and magnitude, as well as potential fluctuations in blood glucose. And these can be associated with, these can provide high and low glucose alarms. And in the case of certain devices, such as the Dexcom device, these can be predictive as well. So if the blood glucose is predicted to fall less than a certain value in 20 minutes, you can get an urgent low soon alarm. And in the outpatient setting, a huge number of studies have taken place to confirm their accuracy and their benefits in that they improve glycemia and HbA1c, as well as increase satisfaction for individuals wearing them, reduce fear of hypoglycemia, as well as improve quality of life and reduce admissions with diabetes emergencies. So as most of you will be aware, the NICE guidelines earlier this year were updated. So for all people with type 1 diabetes, they will be eligible for a form of glucose monitoring technology, as well as for people with type 2 diabetes who are on multiple daily insulin injections or have any other certain indications for this technology. And with over a quarter of people coming into hospital having diabetes, it is very likely that we are going to be seeing an increasing number of people wearing a technology and coming into hospital. And so the JBDS guidance are going to cover CGM as well as insulin pump therapy. And there already is some guidance from the insulin pump therapy in hospital from DTN, which is the Diabetes Technology Network, and then also hybrid closed loop systems. And this will be coming out hopefully in the next few months. So here, I didn't want to spend very long sort of talking about this, but I think the important thing is about recognizing which form of technology the individual who comes into hospital is wearing. And that's quite crucial because there was recently a case a little while ago at another trust that I heard about, where an individual who came in and had what was initially thought to be the Freestyle Libre, so a CGM device that was being worn at the back of the arm, removed. And actually this turned out to be a patch pump, which was a pump that was tubeless. And so unfortunately, that individual then went on to have a ketotic episode of ketosis and potential harm. And therefore, it's quite important to recognize what individuals are coming in with. So whether this is an insulin delivery system or whether this is a glucose monitoring device. And in terms of the benefits of CGM in hospital, I think it's needless to say that it's less labor intensive. So there are certainly benefits that can be had for nursing staff, as well as less finger prick testing, which can be painful for individuals, and provides continuous glucose monitoring throughout the course, as well as customizable alerts and alarms. But the challenge with CGM is that it measures interstitial glucose rather than blood glucose. So what that means is that there can be approximately a 10 to 15 minute time lag, and this can be potentially affected by people who are in hospital in particular, because whilst they're unwell, they may have temperature from sepsis, their hydration status may be impaired with dehydration, or there may be changes in blood pressure, which can affect tissue perfusion and affect the accuracy of these devices. So just to summarize in terms of when people come into hospital and wear CGM, if they are well enough and want to continue monitoring their own blood glucose, then it is safe for them to continue glucose monitoring. We would suggest leaving the alarm settings as they are in the outpatient setting, or they can be switched off, and we'll come on to that shortly. And they should continue having at least 2 capillary blood glucose readings per day. And again, I will talk a little bit more about that. If the individual has an episode of hypoglycemia, so falls less than 4 millimoles per liter, you would follow the standard hypoglycemia pathway, and all hospitals will have local guidance around that. It should be corroborated with a capillary blood glucose as well, and you would treat the hypoglycemia as per local guidance. If the individual is incapacitated or unable to self-manage their own glucose monitoring device, and don't forget, for some glucose monitoring devices, they need to be swiped, so that is the Freestyle Libre, or if they're requiring an admission to ITU, then we recommend removing the CGM device and storing that in a safe place. Some of the sensors can be disposed of, so if you know what the sensor is, and are happy to dispose it off, that's fine. But with some of the older devices where the sensor sits in the transmitter, for example, the Dexcom G6 or G5, you don't want to throw away that transmitter. So the safest thing to do would be actually just store it somewhere safely so that that can be corroborated and looked at then later. And if the individual is unwell, in a hypoglycemic emergency, has presented in sepsis, or is hypotensive, and these are going to be the vast majority of people who are coming in on an acute medical take, then although it is fine to leave the CGM itself, we'd recommend not using the CGM during that period of time. So you would revert to standard capillary blood glucose monitoring. And then once the individual is stabilized, their blood pressure is above 100 millimoles of mercury systolic BP, then the CGM can be continued. And again, just to highlight that CGM is not recommended to guide the adjustment of variable rate insulin infusion and fixed rate insulin infusions at present. And there are a huge number of studies that are taking place in each of these settings that we've sort of talked about. But at the moment, these guidelines will be based primarily around the safety of individuals. And as further evidence comes across, it is likely that these guidelines will be updated over the next few years. So in terms of CGM and surgery, and I think needless to say, before sort of embarking on any of that, you need to get the anesthetist very closely involved with the diabetes team for anyone who's going into a procedure with the CGM device there. The CGM can be helpful to guide the glucose monitoring that takes place during surgery, but should not be used for treatment decisions. And then we would suggest checking the CBG after any procedure takes place, just to make sure that that CGM device is still functioning properly, particularly after diathermy. For any minor procedures like OGDs or colonoscopies, then the CGM device can be continued, but we would recommend placing the sensor away from the operative site or any diathermy pads. So for example, for cesarean sections, which are now increasing, women continue to wear their CGM during a cesarean section, you would advise them not to wear the CGM device on their abdomen, and they could move the site, such as the Dexcom, which is now licensed for wear at the back of the arm. I haven't gone very much into all the individual studies that have taken place, because there are so many studies out there in each of these different settings, and this is a very rapidly and advancing field. But I thought I'd just highlight this paper that was published in Diabetes Care just earlier this month with regards to the performance of Dexcom G6 during cardiac surgery. And that's using extracorporeal circulation, which is a hypothermic procedure for which most cardiac surgery, which happens during most cardiac surgery. And what you can see here is during surgery, the MARD, which stands for the mean absolute relative difference. So that is the accuracy between the CGM sensor glucose and the reference blood glucose that was used during the study itself, was 23.8%. Now, in terms of suitable accuracy for these devices, ideally, we would want them to be less than 10%. So you can see here that the accuracy is quite significantly affected during the procedure itself. Then during hypothermic ECC, the accuracy or the MARD is even higher, suggesting that the accuracy of the device is affected even more. And then post-surgery, it improves back down to 15%, again, suggesting that the accuracy of the CGM device has a tendency to recover post the procedure itself. So this is to just highlight that all the different studies that are getting done in terms of the accuracies and how they can be used within the inpatient setting. In terms of using CGM during radiology imaging procedures, no CGM device is currently labeled or licensed for use of exposure to X-rays, CTs, MRIs, diathermy, or radiation. However, we have lots of sort of case reports and other studies which have used these devices. And in terms of using CGM in X-rays, it's probably okay. In terms of it being used in CT procedures, again, it would probably be okay, but the guidance is that each individual center may choose to individualize their guidance. And those that have used a lead shield to protect the CGM device have actually found that their accuracy and device is intact without any problems. But it is likely that each individual trust is going to individualize their guidance with regards to that. In terms of MRI procedures, now this is with absolute certainty that all CGM devices should be removed during the MRI procedures itself. And then during cardiac arrest situations, now there is no data on this. Ideally, the CGM device is removed for external DC cardioversion that may take place in a cardiac arrest situation. And the reason for that is because there is a theoretical risk that the energy that may get dispersed through the sensor, as some of the metal within the sensor may act as a conductor. However, certainly one should not delay CPR or resuscitation for this, and trying to find where this device is placed. So it is just to be aware about that if it does get spotted, it's worth removing, but not to delay CPR or resuscitation for removal of the CGM device. And then glucose monitoring through the CGM device itself should not be used to guide any treatment of hypoglycemia in a cardiac arrest situation. In terms of documenting CGM readings, currently most of the CGM data that comes through will not be integrated in any of the hospital trusts across the UK directly. So we do recommend documentation of just a minimum standard of blood glucose readings. So that includes fasting, pre-meals, and before bed readings. And then if any of the trusts are documenting this, it's important to have identified whether this is a CGM reading that's being documented or whether it is a capillary blood glucose reading coming through your point of care device itself. And then any episodes of hypo or hypoglycemia that get documented, again, it is worth mentioning whether that is through the CGM or through point of care glucose monitor. As mentioned earlier, so individuals who are in hospital should have at least twice daily capillary blood glucose monitoring, and that's irrespective of whether the device itself needs any calibration. But it is really important to explain to the person with diabetes, because most of them who wear a CGM device outside the hospital setting are going to be assuming that it's perfectly fine for them to use the CGM in hospital and not quite understand why they're needing more frequent blood glucose monitoring in hospital. So it's quite important to explain to the individual that it is necessary for safety reasons, particularly to ensure that the accuracy is intact, and as well as for alerting staff to any out of range glucose readings that may come through from the CGM device itself. And then there's a lot of education that's required for nursing staff as well to be aware about when to perform any additional capillary blood glucose testing, especially if there's any discrepancy with symptoms itself. And then if there is a discrepancy with the point of care glucose, then more frequent capillary blood glucose monitoring is advised. And then if that a discrepancy persists, then we would recommend removing the sensor and replacing it with a new one. In terms of the discrepancy itself, we've used a definition which is known as the percentage 2020. And what that means is that if a individual's glucose or reference glucose is greater than 5.6 millimoles per liter, and the absolute difference between the reference and the sensor glucose is greater than 20%, that would be defined as being a significant discrepancy. Or if the sensor glucose if the reference glucose is less than 5.6 millimoles per liter, and the absolute difference between the reference and the CGM glucose is more than 1.1 millimoles per liter, then again, that would be defined as a discrepancy that's there. And that's defined on the standard isometrics that get used to report accuracy for CGM devices in all the studies. So situations in which to check capillary blood glucose. So certainly if an individual is having hypoglycemia and is needed to be confirmed, or for monitoring recovery from hypoglycemia. If there's any concerns that the symptoms are discrepant and do not match the sensor glucose, then checking a capillary blood glucose would be important. Or if there's any concern that there might be an erroneous reading, or if there's a requirement for calibration, although I know that most of the CGM devices now will not be requiring any calibration. Also, if an individual has recovered from an episode of hypotension or has come out of surgery or any procedure, then checking the accuracy of the CGM would be important. So alerts and alarms, which are integrated into the CGM systems, alarms may be kept as they are within the outpatient setting. But if they are being used to alert the medical team, I think it is worth recognizing that the medical team or the nursing staff probably don't want an alert all the time coming through if the settings are set quite low. So they may wish to push the settings a bit higher. So you may wish to have the alarm set at 15 or 20 millimoles per liter, where extra insulin would be considered. And a low alert set at perhaps 4 to 5 to avoid impending hypoglycemia or looming hypoglycemia, as is now known. So just a quick question. So if an individual with type 1 diabetes comes in and in the outpatient setting when they're usually fit and well, what would be the optimum or what would you be aiming for in terms of the target percentage time and range? And this is in the outpatient fit well person setting.
I'll just give about 20 more seconds and then I'll show the results. And in the interim, I think there's a question in the chat. How practical is it, in your opinion, that the inpatient nurses or non-diabetes team will pick up the discrepancy and will start doing more frequent blood sugar more frequent CBGs?
Yes, so I think that it does get picked up because actually individuals who are using the devices itself will notice it and pick it up if there is any discrepancy there. But I think it comes back down to the education that's required for inpatient nurses, which is the same as any capillary blood glucose monitoring that gets done. The education behind that is needed. In terms of the picking up discrepancies itself, again, it comes back down to education that is there, or that is needed.
I suppose Natalie has made the same point about training of nursing staff, also healthcare assistants, as well as awareness and training of general physicians and surgical colleagues.
Absolutely. Yeah. So I think this is the reason why it is going to take a little bit of time before hospital trusts are comfortable and familiar with using CGM devices in hospital, because it will take a little bit of time for each of the non-diabetes teams to become familiar with these devices. And in the example that I gave earlier as well, we wouldn't want people to come at harm because of the lack of understanding of what these devices are. So whether this is an insulin delivery system versus a glucose monitoring system. So I think there's a huge amount of education that is going to be required. But I think the first step here is actually having some clear guidance as well as to what teams can do in the hospital setting. And we don't have any guidance nationally in any of the trusts for this at present. And this was part of a nationwide survey that was conducted by JBDS IP as well. So I think there's a lot of work to be done, but I think that certainly there are benefits to be had from using CGM in the long term. So I can see the poll results.
Yeah.
So 88% have gone for B, which is 70%, which is absolutely excellent because that is in keeping with the international consensus time on range by Battaglino et al. That was published back in 2019. So just taking you very quickly, some of you who see people in the diabetes clinics in the outpatient setting will be very familiar with for people with type 1 and type 2 diabetes, the injections, the target time and range between 3.9 and 10 millimoles per liter is greater than 4, less than 3.9 millimoles per liter. We would aim for less than 4%. But in hospital, time and range is unlikely to be suitable for people who are unwell. And that is because of fluctuations that they will get on a day-to-day basis from their illness. Or for example, if they're on steroid treatments and things that may send their blood sugars higher than what would normally be expected. So the main priority here is to minimize hypoglycemia and aim for percentage time below range, so that's less than 3.9 millimoles per liter of less than 1%, and avoiding hyperglycemia as best as possible. The usual targets for in the inpatient setting of 6 to 10 millimoles per liter would apply for the acutely unwell individual, but these can be individualized as well. So for example, for people who are more frail or elderly, that target may change to 6 to 12 millimoles per liter. And then particularly for the range of looming hypoglycemia, which is between 4 and 5.9 millimoles per liter, if there's a CGM downward arrow, that is likely to suggest that glucose is trending down and there is impending or looming hypoglycemia, and therefore treatment may be warranted earlier at that time. How are we doing for time, Kavita? Do we have just have a couple more slides?
I think we're okay. Yeah, we're okay.
Perfect. So I'll just briefly touch on the hybrid closed loop setting and where we are at present. So there are very limited data and guidance on real world use of hybrid closed loop settings in the hospital itself. And if an individual is well and they're coming in for a very short elective procedure or an investigation, the JBDS guidance is going to recommend that it may be appropriate to continue a hybrid closed loop system, but that is again in very close conjunction with the diabetologist as well as the anesthetic teams and the surgical teams during that procedure or setting itself. However, if an individual is unwell, then the automated hybrid closed loop algorithm should be disengaged, and you can switch it over to a manual control in the hospital setting. And again, that's possible to do by letting the individual know, and they'll be able to switch that themselves. And if not in the inpatient setting, otherwise what happens is, as you normally would, you would take the individual off everything and put them on either variable rate insulin infusion or subcut multiple daily insulin injections, if there are any concerns and people are unfamiliar with the system itself. And for any individual to then continue in manual mode, they need to be able to self-manage as normal, either the pump or the CGM. And like I said earlier, if there are any concerns at all there, the safest thing to do would be to take them off it. So in terms of the challenges and future directions overall, and as was touched on earlier, I think there is a huge need for the upskilling of hospital staff. And this is going to take time, but I think the first step here required is for all of us as endocrinologists, diabetologists to become familiar with these devices in line with the guidance that is out there, and for diabetes teams to support its implementation. And there's a huge national variation in terms of specialist input that's available, particularly during out of hours, on calls, weekends, etc. So there is some thought that each individual trust may need to consider when putting into place any local guidelines. There are also a need for further accuracy studies in specific hospital populations, and I haven't particularly touched on that here, but in terms of the guidance that is going to come out, there are certain hospital populations, such as those who are on hemodialysis and peritoneal dialysis, where further accuracy studies are going to be needed. And then in terms of the benefits and the CGM metrics as well, there is very little or mixed evidence around that. So there is certainly a need for novel target CGM metrics in hospital, as well as long-term outcome data, particularly for, individuals who maybe post MI, strokes, or bypass surgery. And the clinical outcomes and cost effectiveness overall yet need to be determined as well. So really, just to summarize, I think the technology with CGM has the potential to improve in-hospital diabetes care. There are going to be some clear challenges to its implementation that have already been highlighted just from all of you there as well. And then the JBDS IP technology guidelines are due later 2023, not 2022. And then local guidance is likely to follow as well in suit. Thank you very much. And any other questions?
I think there's just one comment about Cambridge has started with few patients recruitment for inpatient closed loop system. It has very good outcomes, but selective criteria is very challenging.
Correct. So I think that is a very exciting study. I think they've just submitted a paper that the real world setting paper is likely to be published soon. But you're right in that they're very selective criteria. I think that the criteria for the inpatient closed loop systems were used in type 2 diabetes, specifically for that study, and not with type 1 diabetes. But if you are aware and know, that would be good to know if it's used in type 1 as well.
I'm not sure, Ted, is there any updates on what type of diabetes they've started recruiting?
Yeah, actually, we got 18 patient recruitment. I think they presented yesterday only. It was done last year, actually. So actually, they recruited those patients who are in like a very good prognosis, patients who stay in ITU, or maybe the patients actually on the TP and infusions. And it's kind of like short surgery, that patient who is just buying time and to make sure that glucose control is stable during the time of the recovery, while the patient is awaiting the time until they reach the recovery time. So that's why the selection criteria is quite challenging, regardless of type 1 or type 2. Mostly they are type 1, I believe.
It's very interesting.
Yeah.
Yeah, I think this is a very rapidly advancing field. So I think there is a lot of potential. The next comment is about the wealth of data that CGM offers, and I completely agree about it. I think, as with everything, the wealth of data that CGM offers can be, very useful. It can prevent iatrogenic hypoglycemia, and we know that hypoglycemia outcomes in terms of readmission rates and mortality is increased in those who have inpatient hypoglycemia. So as with all things, I think that there will be challenges in the inpatient setting. However, they can be used to the benefit as well in preventing hypoglycemia.
I think, like you said, a lot of people need training and lots of guidance, which will be quite interesting in the next couple of years.
Yeah, I think it's likely to take a lot longer than that, because if this is over the next few years, and I think this will take longer than a couple, but CGM, if the evidence is there for its safety in particular settings, I think we're likely to see that for most people, the standard of glucose monitoring may shift slightly as well. And there will certainly need to be a huge amount of education that goes with it.
Vinit's made a comment that this might be similar to the cardiac monitor alarms.
I think very much so, to some extent.
Thank you very much, Pari. That was very useful. Thank you again.
Thank you. If there are any other questions or anything, I'm very happy for anyone to email or contact me. Thank you all.
Thank you. Is Elizabeth on already? Yes. Hi, Elizabeth.
Hi. I think I'm coming up on the screen as Kavita. So.
Oh yeah, that's okay. That's absolutely fine. I was wondering as well why I'm locked in, but okay.
Sorry. I don't know why I used the link and it brought me up to your under your name. So apologies for that. It was very interesting to hear from Professor Miran and then Pari about their topics. And I think it's obviously a slightly lighter topic. So I hope everyone will remain on the training. Happy to answer questions as we go, and I'll have some time, I think, in the end as well. Try to keep it light and go through quite a few information. So I was asked to talk to you today about carbohydrate counting and how we use that for the management in type 1. And within this context, I'll go through the what, the which, and how we teach patients to carb count. I have to say, this is primarily in the outpatient setting. It's not always very appropriate in the inpatient setting because of all the parameters that I guess Parry mentioned as well, and the complexity when it comes to stable blood sugar levels in the inpatient setting. I'm going to go through what makes a patient pump start ready from a counting perspective and put that in context. Briefly talk through different settings that we could use on a pump. I don't know if it will be of interest to you, so stop me if it's not, but I thought it would be interesting to cover because it's something often patients ask us about. And
that'd be really good. Thank you.
Yeah, and then I'm happy to take any questions you have. So let's give it a start. So starting, I guess, with what is carbohydrate counting? It's calculating the amount of carbohydrates in the food or drinks in order to match the amount of insulin, specifically using a specific insulin to carbohydrate ratio. So going to very simple biology, I guess, thinking about carbohydrates and what they are. A nutrient may be carbohydrate, protein, or fat. Carbohydrates is a source of energy, and it's made up of sugars and starches. And when we're thinking about sugar and starches, we're thinking about them breaking down into glucose. So your carbohydrates will break down into glucose, your proteins into amino acids, and your fats into fatty acids and glycerol. So starting with which foods, I guess, contain carbohydrates, we have slightly different groups. And when we're looking at the foods and we're thinking about carbohydrate counting, our first group will be our grains. So your pasta, your bread, your rice. Then you have your dairy options, which are mainly your milk and your yogurt. We don't really include in counting cheese, primarily because it's fermented. So you don't necessarily have the same amount of lactose, which is the sugar you find in milk and yogurt. Then you have your fruits over here, and that's all fresh, but it dried, fresh, tinned, juice, all counts. You have sauces like ketchup that will have added sugar, sweets and confectionery, chocolate, and you can see here the cereal as well. So quite a lot of different sources that will have sugar. So starting off with a question, I guess, to all of you, what do you think of the three items here will cause the biggest rise in blood glucose? And I guess adding to an option of E and F before you make your choice, thinking...
sorry, Elizabeth, I think someone said unable to view slides appearing blank. I can see the slide. I was just wondering if anyone else can unmute and tell me if they can see the slides. Yeah, I think it's working fine. Riaz, I'm not sure if you want to log in and log out, log in again, because I think most of the other people are able to see. Yeah. Okay. Thank you so much, Elizabeth. I'll start.
Okay. I'm happy to share it with the person that couldn't see, or I can go through them again. So what I wanted to ask you here is, I guess, which one has the biggest rise in blood glucose? So is it the apple? Is it the slice of bread? Or is it 3 cubes of sugar? And maybe as an option E, we can say none of them, or, all of them would have the same effect, is option F. I'll give you a few minutes to answer that.
Okay, I'll just wait for 20 more seconds, okay, and then I can show the results.
Yeah.
So A is apple, B is a piece of bread, C is sugar, and D is all will create some rise in blood sugar, and E is nothing. It's the same.
It's the same. Okay. Apologies for not putting all options on the image.
That's absolutely fine. Okay. Okay, I will end the poll and just share the results.
Okay, interesting. So I think there's a little bit of a spread between A, B, and C. So actually, the correct answer is that, well, all 3 items are about 15 grams of carbohydrates. So your apple will be about 15 grams. Your bread will be roughly about 15 grams, a small slice of white bread, and your sugar will also be 15 grams. So you would probably expect a similar rise following the consumption of all items. The caveat here, I guess, is that yes, sugar might give you a higher spike, but in terms of the rise of the blood sugar level, you would expect all three items actually to have equal effect on your blood sugar level within reason. So that's just to give you a perspective of the amount of sugar in different items. And I guess thinking about whether we ask patients to inject for an apple, when we would always ask for a patient to inject for 3 cubes of sugar. And that's where I think nuances come in. So give me 1 second, because for some reason, oh, there we go. So thinking a little bit about the foods that we don't count when we come to carbohydrates, we don't really count our vegetables, because although they contain some carbohydrates, it's actually so low that and the way that the carbohydrates in vegetables is absorbed is so slowly that it doesn't necessarily you don't necessarily need to inject insulin for your veg. Equally for your proteins, unless they're breaded, we wouldn't necessarily count any carbohydrates for that. Your fats, again, not really. Cream, and you can see here the cheese and the avocado, you wouldn't. I'll come back to the pulses later, because pulses do actually have some carbohydrates, but we often need to think about it in a different way to the carbohydrates that we mentioned earlier. Kavita, did you want to ask something?
Yes, someone just asked in the chat whether yogurt contain carbohydrate.
Yeah, so yogurt you would classify, so just to clarify, this is cream, not yogurt, but yogurt will actually come under the same category as milk. And on the basis that it has lactose, it would actually give a rise to the blood sugar levels in a similar way that you would expect other things to. And patients will have to account for it when it comes to counting. I guess the one thing to mention here, and where we perhaps combine carbohydrate counting with the food distribution and constitution, is that foods that are very high in protein and fat and are high in carbs often have a differentiate effect on our blood sugar level, in that you have fat and higher protein amounts slowing down the absorption of your carbs. And in that way, we sometimes need to rethink the way that we administer the insulin. And I'll come back to that when we're talking about administration through pumps, but I can touch on how we manipulate that with daily injections as well. So in terms of clearly educating patients to carbohydrate count, we don't waste time counting any of these foods, because that's time that you can use to just enjoy your food. So don't spend any time counting these foods. So I thought it would be good to go through a specific meal, and together we can work out how we would count this specific meal. So the meal we have today, and I hope no one's hungry, I hope you've all had lunch, is beans on toast with cheese and a dollop of ketchup and a glass of orange juice. So thinking a little bit about the different parts of the meal, we have 2 slices of bread, we have a thin spread of butter, we have tinned beans, we have a small matchbox-sized cheese, 2 tablespoons of ketchup, and a small glass of juice. So which parts of this meal, and I'm not sure, can you select multiple answers on this?
I'm afraid you can't.
What a failure to the system. That's okay.
I think people can type in the chat if they feel that they need to answer more than.
Okay, try that. Try the chat instead of the poll, because the poll won't work. And in the chat, you can probably put the letters instead of the actual words if it's easier.
So someone's typed ACEF. Well, 2 persons typed ACEF. 3, 4, 5.
Yeah.
Juice, beans, ketchup, toast.
Okay. I think we're getting agreements here.
Okay, I'll just show the results, because I think
okay, perfect. Okay. I think more or less everyone's come to the right conclusion. So I think you've definitely been listening in terms of which foods contain carbs. So we have our bread, we have our beans, we have our ketchup, and we have our small glass of juice. And I guess with your butter and your cheese, we don't necessarily care about those, so we're not going to count them. Perfect. Okay. So if we start with, give me 1 second. There we go. If we start with thinking about how we're going to look, I guess, where we find the carbohydrate amounts, a very useful tip is for foods that actually have food labels, look at the food labels, and often food labels tend to be accurate. If it sounds too crazy in terms of the amount of carbs, probably there's a mistake or a typo on the label, but often labels are accurate actually. So how do we find out about carbohydrates on labels? So you'll often see at the front of the pack the traffic light system label, which although it has a lot of information and it can be very useful for patients to try and opt for balanced options, I guess, it actually only depicts amount of sugars, and that doesn't necessarily incorporate the whole amount of carbohydrates in the meal. So you actually do need to look at the full label on the back, and that's what we often suggest to patients. So a lot of packs will depict information per 100 grams. So it's very, very important to try and relate it to the portion that you're actually consuming, especially if it's a pasta or a rice or a cereal, where often we open a pack and we don't necessarily have pre-portioned, unless it's, you know, porridge or something like that, pre-portioned portions if you want. So always very important to think about what the patient's portion is, because also often it doesn't coincide with serving size. So going back to our 2 slices of bread, we can see that each slice contains about 20 grams. So because we're having 2 slices of bread, we're going to have 40 grams from our bread, as the label says. Moving on to the ketchup. Often we use metrics like teaspoon, dessert spoon, tablespoon, because it's easier for patients to actually estimate the amounts with that. Within that, my spoon and Kavita's spoon are actually different size, and we both value them as a teaspoon, when in actual effect you might have even 5 grams difference. And the significance there is that if a patient is giving 1 unit for every 5 grams, that difference can actually have quite an incremental effect on their blood sugar levels. So that's where we need a little bit more accuracy when it comes to amounts. So we're having 2 tablespoons. So we can see that 1 tablespoon is about 3.5 grams. And then conversely, we are having 7 grams from our ketchup. With the juice, again, you would be looking at the label. The label gives you the amount per 100 ml. So again, you need to think about how much that will be for your portion. And thinking a little bit about the juice, you would probably say in 100 grams, I have X amount of carbohydrates, and then related to the actual portion. And this is the formula we often show to patients to try and navigate the how to work out the amount in their own portion. I have to say, not despite people having diabetes for a long time and having to adjust their insulins, and numeracy is not always a strong point for everyone. So simple ways to estimate portion sizes is quite useful to navigate carbohydrate counting and make it a little bit easier and more manageable instead of daunting. So applying this formula in this example, I'm not going to ask you to work this out, but we would end up having about 20.5 grams of carbohydrates in our glass of juice. Now,
sorry, I think someone's just asked in the group, do we consider beans in pulses?
Perfect. So we've just come up to that example, so we can go through it together. So when we are looking actually at baked beans, and different people will actually estimate baked beans in different ways, and I'm not sure if any of you have completed Dr. Daphne for Doctors training, because this is covered in more detail. But in terms of the beans, you have an option to think a little bit about the constituents of the beans. You don't necessarily count for the beans, but you count for the red sauce that is in the beans, and often that will cause a bigger spike in the blood sugar level. So in this case, and only in this case, you would be focusing primarily on the amount of sugar, expecting that that comes primarily from the tomato sauce. And then you would be looking at the 8 grams in the half a can there. I hope I've answered your question, because I can't see the chat, but that would be one way of looking at it. In the context of Daphne, often what if you do account for your beans, what you might do is you might attribute double of your ratio. So for example, if a patient normally gives 1 unit for every 10 grams, for your pulses you would be giving 1 unit for every 20 grams, which is quite a big portion in the end of pulses to consume. I hope that makes sense. The key reason why we need to be more careful with beans, lentils, most of the vegetables and nuts is that if you end up attributing insulin for those, because of how slowly they're absorbed, your insulin might take effect prior to your blood glucose actually raising. I have to say, because of the use of pumps and the more sophisticated, if you want, administration of insulin through a pump, you might be able to utilize insulin better when it comes to these more slowly absorbed carbs with the use of a pump. With daily injections, it's often very difficult, and for that reason, we often don't advise to take this into account. I have to put that in context. If someone has a very large amount of nuts, let's say cashews, perhaps they will have to inject some insulin, and that will be very much individualized. But as a general rule, we wouldn't necessarily take into account the foods listed. I think someone has asked, how about potatoes? Potatoes would fall in the same category as bread, so we would still very much count it. And sweet potatoes and potatoes would both be accounted for. So they would actually give a spike to the blood sugar level. So you would need to give insulin. So coming back to our example, we have 40 grams from our bread, we have 7 grams from our ketchup, we have 8 grams from our tomato sauce in our beans, and we have 21 grams from our juice. So that gives you a total of 66 grams for that meal. So you can see that it's not necessarily something very, very quick, but over time, what we often suggest is that people make a list of the foods that they commonly eat, and then usually what we would suggest is that next to the list of foods, they have the amount of carbs, so that if at different times the ratio change, then it doesn't necessarily impact what they have written on their list. It's just that you divide the amount of carbs to your current ratio. I'll explain that on the next slide. Yeah. So one thing to mention, I guess, is that in terms of more fluid foods like pasta and rice, often it's important to be careful of how labels depict information, because it can be cooked or uncooked depiction of information. With uncooked pasta, the percentage of carbohydrates is closer to an 80%. With cooked pasta, it's closer to a 30% of the weight. So the amount of carbs will be the same, but the weight will be different if a grain is actually cooked or uncooked. So it's always important to look at the label and understand what you're seeing. In terms of resources that we use and we share with patients, Carbs and Cals is the most up-to-date list in terms of listing foods that people eat. Sadly, it's not a free resource, so it's something people have to purchase from their own money. So there's an app and there's also books, and it varies whatever people prefer to order. And then I guess you have other websites as well. However, what we need to be careful is the accuracy of the information that is added, because often if users add information, we're not always certain as to the accuracy of the information that is depicted. So we have our food labels, we have carbs and calories as a resource, and you have the internet as well for more branded I guess foods that you can find by just searching online. So thinking a little bit about the impact of inaccurate carbohydrate counting, and I guess I spoke about that when we spoke about the different sizes of your spoon and what difference that can make. So 10 grams of carbohydrates without insulin will often raise blood sugar levels by about 2 to 3 millimole. And 1 unit of insulin on average will drop a blood sugar level by 2 to 3 millimole. So conversely, miscalculating the amount of carbohydrates in a meal by 10 grams or even by 20 grams can have quite a significant effect, with someone having a level of 9 or 10 after they eat, and then conversely having a level of 12 or 13. And then that would be classified as hyperglycemia following a specific meal. If carbohydrates also are miscalculated or over calculated, then you end up with too low levels, and that's often also another risk that we want to eliminate. So thinking a little bit about other considerations apart from carbohydrate counting, Pari mentioned being unwell, so you'll have rises in the blood sugar levels because of that. Miscalculation can always be another reason. Just relaxing instead of having your usual routine, stopping or not taking insulin for specific meals, or even not taking insulin, that could cause a rise as well. And thinking about blood glucose going low, we're thinking about aerobic exercise, alcohol over time, I guess, and giving too much insulin, and also heat. So I'm sure you're all familiar with these things, but it's just when we look at CGM, or we look at the profile of blood sugar level, we always need to have these parameters in our mind to make sure that we're on board with what's going on. So in terms of moving on to pumps and thinking when someone is pump ready, I guess from a diabetes perspective or dietitian perspective, we often want people to be competent with carbohydrate counting prior to moving on to a pump, primarily because then pumps can be used at their best capacity, because you can adjust in a better way using the amount of carbs and importing that in the pump. So I guess the one thing is ability to identify foods that contain carbohydrates. The second part is accurately being able to find the information, applying your insulin to carbohydrate ratio at a specific meal. And that can vary from meal to meal. It doesn't necessarily mean that because a patient has 1 unit for every 10 grams with their breakfast, they will have the same ratio throughout the day. And then the next bit will be ability to adjust the insulin dosages according to circumstances, different types of activity, different settings, and so on. So moving on to thinking a little bit about the different boluses. This first image here would show a normal bolus, and this is how you would expect, I guess, someone that is doing a manual injection. So you have an injection at one go, and often it's something you do with most foods. With most insulins, Novarapid, Humalog, you would have 20 minutes ideally before meal to optimize the effect they have. In terms of how you do it, the insulin is given immediately. There isn't any delay in the amount that is given. And often what we say is try and test or look at the profile of the blood sugar level before a food is consumed, and then 4 hours later. With the more recently released insulins like Fiasp and Lumjev, perhaps you would be looking at a window of about 2 hours after. a meal as opposed to 4 hours, just because the tail is a little bit shorter compared to Novorapid. The next bolus, and this is something you can do only with your pump, would be to try and prolong or square your bolus. And this is more rarely used, but it can be quite useful for patients that have gastroparesis or a more delayed gastric emptying. And that's why I've put the, I guess the buffet, because you tend to graze a little bit over time. And it might be that that pattern works better in that setting. So not necessarily something everyone does every day. So there you go. That's an option. So the options will vary depending on which pump the patient has. So different pumps will have different brackets, and usually it's between 2 hours to more recently, I think Omnipod has the Omnipod Dash actually has a more prolonged time in terms of the timing that you can set your square bolus. And again, with this one, you would test before and at the end of the extension, whatever that is, and then 4 hours after that, on the basis that the insulin works for 4 hours. So it's a Novorapid or a Humalog. If it's a Fiasp, you would be looking at the 2 hour mark after the end, so after the edge of this red bolus. Your combination bolus is one that you can use very effectively with foods that are lower GI foods, or have a particularly high fat meal, more than 25 grams. So then you would be thinking about an Indian curry, or in terms of your higher fat meals, I guess, or a burger with a milkshake, something like that. Basically, you would be looking more on this. And most of the evidence shows that you want to aim for a 60 to 70% immediately. So this is your first injection, and then you extend the remaining over 2 to 4 hours, depending on what the constitution of the meal is. Again, the prerequisite here is that you've worked out a ratio so that you know what the total amount of insulin is for the amount that you're eating, and then you manipulate the way that it's administered. In terms of thinking a little bit about the combination bolus and how we can mimic that in someone that has a daily injection, you would be thinking about doing an initial injection of 60 to 70% about 20 minutes before someone needs, and then you would be looking to do the 30 to 40 about an hour later, and then you would create a similar potentially pattern to that. It doesn't necessarily work for everyone, but sometimes it does work, and patients tend to like it, especially with foods that are a little bit more high fat, so maybe a pizza or something like that, and it can be quite useful. In this case, you would test before and at the end of the extension again. So thinking a little bit about the whole effect of the blood sugar level. And then finally, you have your super bolus, which is quite rare actually for patients to be using. I haven't necessarily had a lot of people keen to use that. So you would be looking at using that with high GI carbs. And the way that this is manipulated is you use 1 to 4 hours after your basal rate, and you put on top of your bolus. So you end up basically with a temporary 0 basal rate, but you actually have the insulin on board in advance. And often that's useful because higher GI carbs end up giving you a bigger spike initially, and then a bigger drop or a faster drop later on fairly quickly. So again, in this case, you would check before and an hour and 4 hours later to see what has happened. And I guess with CGM, it's always easier because you have continuous glucose monitoring. So it's easier actually to assess the effect of those. So in summary, carbohydrates to count include starches, fruit, dairy, which includes milk and yogurt, and sweets and confectionery. The tools we use are nutritional labels, weighing scales to weigh, for example, the pasta or the rice, and Carbs and Cals, the app or the books. Accurate carbohydrate counting is important to control the levels tightly. It's not just food and drinks that increase our blood sugar levels, and there's different boluses that we can use, both in daily injections and also in pumps that can be quite useful in the way that we see rises in the blood sugar levels. I think someone has asked what would be the examples for super bolus.
Yes.
So for super bolus, you would be looking potentially, and I'll go back, you will be looking at a pizza or your meals that will be higher GI. So certain cereals will cause a bigger spike depending on the load that you're having. So it might be useful in those cases. I think to put it in context, you would use a super bolus, but you would probably first trial a combination bolus prior to moving to a super bolus. Because if you don't see an effect with a combination bolus, maybe you need bigger load of insulin initially, and you might find that that suffices. Yeah. So in relation, I think someone has asked in terms of hypoglycemia treatment and hybrid pumps and what we recommend in terms of treatment of hypoglycemia. So I think I would agree with that often we don't advocate for additional carbohydrates. So to put this in context, as it was classified earlier, we would be looking at a hypoglycemic episode below 4 or below 3.5, whatever the marker you're looking at that time. And for that, you would still treat. So you would still give your treatment of 15 grams of fast-acting sugar. And we saw that that could be 3 cubes of sugar, not necessarily your bread and your apple, because that, although it contains 15 grams, is not a fast-acting sugar, so it won't necessarily go to your brain fast. The reason why you don't necessarily need to give the additional snack after that we used to recommend is that you have a good control of your basal insulin. So if needed, basal insulin can be temporarily reduced, and then there isn't the need for that additional snack overnight or during the day, really. But I get that would be individualized. We don't routinely suggest that you reduce your basal insulin following a treatment. It's just not needed. With closed loop, that will be eliminated because the actual closed loop reduces the rate at the administration of the insulin to avoid low levels. So I think someone has asked, could you go over the square bolus again? So your square bolus basically is almost an elongated bolus. So the way the pumps get set up is you go to you first add the amount of carbohydrate in the pump, and then as a second option, most pumps, actually all pumps that we offer, will give you the option to use the carbohydrate wizard, and then there's where you put the timing. So you could set the time as 10 units over half an hour or 10 units over 2 hours, and so on. It can be very useful for patients with gastroparesis because they well, it can be useful because you often have slower digestion, I guess. Sorry, can I just say, I think someone has said in terms of the square bolus and MDI, you cannot mimic square bolus in MDI unless you manually inject 2 units every, or 1 unit over. You need to do multiple injections. That it wouldn't necessarily, I wouldn't necessarily advocate for that. It's your combination bolus that you can mainly mimic to a point with your MDI by giving 60 to 70% 20 minutes before and 30 to 40% an hour later. So that's where you might be able to mimic a little bit. It won't necessarily have the same image, but it will probably look similar. In terms of the normal bolus, someone has asked, can you please go back to details of normal bolus? So your normal bolus will be 1 injection. So you dialing on the pump, give me 10 units, and that would all go in once. So then you should expect an equal distribution. Is that clear?
Yes, thank you.
Yeah. I'm happy to answer any other questions.
Does anyone have any further questions? Can either unmute or type in the chat. I don't think there's any further questions, but that was really great. Thank you again for agreeing to do a session. Thank you. Oh, how would you do correction boluses?
Okay. Can I just clarify, Mohammed, do you mean corrections? Do you mean corrections, or do you mean changing the bolus you have requested to administer? Unless you mean correction boluses, meaning. Oh, okay. Yes. So let me go back, because this slide will be more relevant. So if you think a little bit about how much 1 unit of insulin would reduce your blood sugar levels, you often would use that as a guide to give you the sensitivity factor or the correction factor that you would suggest the patient has. And I have to say, 2 to 3 is not necessarily a rule. Some patients might find that 1 unit drops them by 4. Other patients will find that 1 unit will only drop them by 1 millimole. So it's very, very much personalized in terms of where you are. Often we start with 1 unit of insulin theoretically dropping you by 3, or you see where the patient is at the moment. So for example, if let's say they're correcting a level of 16, you assess how many units they're actually giving at a 16, and then using the CGM you can see where their levels are going with that treatment. I think often case you find people might be initially overcorrecting, so it's always important to think a little bit about not just how much they assume a unit will drop them by, but also what level they're aiming to get to, because if that is a little bit off, it could be the difference between getting to a 5 and going below 4, and that would be treated then as a hypo. Is that okay? Is that clear?
Yes.
Hi, sorry, I just had a quick question. Great talk. Is there an opportunity for these pump devices to actually have the carb calculations as part of it? So essentially, the patient can just say, I've had half an orange, half a cup of coffee, and then they input it into this app. The app then calculates how much insulin they need and how to give it, and it's then they just have to press a button and say administer. Is it something that people are looking into?
Yeah, I think that's a really interesting context actually, because at the moment the way pumps are set up, and I guess it's different between closed loops where you have a range. I think you might have already spoken in this in other training sessions, but will you have a certain range and aim for the blood sugar levels to stay at? And Pari mentioned a little bit about closed loops, and that would be your basal rate, and then you have settings that integrated in the pump with your carbohydrate ratios. So not as such, you would, at the moment, you still need to import the amount of carbs, but as soon as you do that, the patient wouldn't necessarily have to work out what that number relates to. And conversely, when you administer a bolus, whatever bolus you're administering to the pump, with importing the amount of carbs that the patient might be eating at that time. And if the pump speaks to your CGM, the pump will also estimate a corrective factor based on the sensitivity factor that the pump is set up as for that time. And then it will be the addition of the two. So in answer to your question, I don't think we are there in terms of having a pump estimate the amount of carbs of a specific food that you type to the pump. But in many, maybe Pari has more information on that because she's raised her hand.
Yeah, I think just to add to that, so I think there are two parts to that answer. I think firstly, in terms of, you can have a bolus calculator which is integrated into a pump or a glucometer.
Yeah.
So if you tell the bolus calculator and input the amount of or the number of carbohydrates, it will calculate based on your insulin sensitivity factors and your insulin to carbohydrate ratio settings that are already inputted into the system, what the bolus insulin dose should be. What it doesn't do is if you say, I'm having an orange juice, and then automatically do it for you. So it doesn't quite translate into the two-step process all the way, but you can have a bolus calculator which is integrated in. I hope that answers that question.
Pari, way more eloquently than I explained it. I definitely second what you've just said.
You know, that's great. I was just thinking, like, with the sort of tech that's available nowadays, you know, whether there could be an opportunity, because yeah, it is quite complex. And as you said, diabetes is now, you know, very common, and the education is going to be a big part of it. And how much technology can sort of take over and help with that would be quite amazing.
Yeah, I think someone has said that there's an app such as Diabetes M that can save the meals, and Carbs and Cows has the same feature. You can actually save your meals but then you would need to input that into your wizard. So as Pari said, you can use a wizard if you use daily injections, because there's meters, glucometers that you can actually set up this meter with. I think it's Freestyle that more conversely used. And then every pump will actually have a wizard integrated in the pump. So that anyone with a pump should have a wizard integrated to the pump, and that will advise them on the amounts.
I guess the problem is saying drinking 220 ml of orange juice, but what brand also makes a difference.
Exactly. Yeah.
So until we get there, scan everything. That's future.
Yeah.
So I think just to add to that, I mean, there are lots of bits that are quite interesting in the research setting as well. So there are a couple of teams that have tried to do it. If you take a picture, it will automatically scan, and using AI, it will work out from your meal plate how many carbohydrates there are and things. But all of that is very much in the research setting, and actually in terms of what is out there at present, it's a standard bolus calculator that you still have to input it into. I think some of the apps as well, I think the apps are good, but you just have to be a little bit cautious about where the evidence-based is for that, because not all of them have been studied in a research setting as well. And that's just something to be mindful about.
Yeah, absolutely.
I think there's just one more question. Is it true if fruit is green, it would contain less sugar than if it was ripened?
No. Are you referring to bananas?
I'm not quite sure. Yes, he said.
Yeah. So, well, the starch is broken down, so you will still have the same amount of sugar, but it will cause a different spike to the blood sugar level. The darker, if you want, or the more yellow or dark the banana is.
Okay. Thank you very much, Elizabeth, Perry, and Prof. This was a really good session. Everything is recorded and should be uploaded on the Imperial Endocrine website in the next couple of weeks, and I will also email everyone who signed up for a Survey Monkey feedback, and we'll get a certificate after. Thank you, everyone.
Bye-bye. Thank you.
Bye.